Good afternoon and welcome to United TV. It's our Bariatric Friday time with Dr. Ergao. Today is November 14th. I have to remember these dates. November 14th, and we are going to have a little bit different session today, different than what we used to do, just so that we just go through the holidays. Next week, we are going to discuss about navigating holidays. Especially for those patients who are going through the bariatric surgery process or they may be post surgery, and also for those who may not have to go through the surgery, you can still benefit from the advice that we are going to give you. So we have three different sections today. So from our more serious, one of them is fun. Hopefully, you will stay with us, and then we'll go through this together. So the first issue, Dr. Gao, welcome to the show again.
Thank you. Thank you. Glad to be here.
Because we see each other every day, so I thought they already knew that you were here. Sorry about that. So now the issue is every time we go through these news coming from the government or the other politicians, the part that we always emphasize the social stigma and what people are going through. They may like what they are feeling in the society with their physical appearance, their health, and morbid obesity is still not classified in the right direction or right category. And unfortunately, Trump administration in this case is even using this issue as like a potential they could deny visas for those who are going to visit. And the logic behind it is so that they would actually, when they are here, they would have more expenses. You know, I don't know how you feel about this, but one thing that I just want to tell, as soon as I hear this, so do we get their A1C level for the visa or their heart condition, or if they have any, STD, or if they have any other problems for, like kidney. So that could be a potential liability while they are here as a tourist. They can have these, but I think our issue today is more about this, the way that this perspective or perception of this issue being still not understood. So I was extremely disappointed, trying to understand where this is coming from, but I was extremely disappointed with this whole thing. Um, yes, we don't, you know, it's not about tourists, it's about what our understanding is about morbid obesity. So, do you have good, understanding of these other health conditions may trigger under this new immigration guidelines? Do you have more information on that? And
Uh,
how do you feel about it? Let's just start with
well,
that
I,
first.
I am I'm very concerned. I'm very concerned because it kind of brings back stories of Ellis Island. You know, when immigrants used to come and were processed through Ellis Island, and there was the issue of excluding people who had certain diseases. So they would be examined. Oh, you have this disease, you cannot come in. That family member can come in, you cannot come in. And people who have traveled for months through the sea to come to America, and the people examining them would have very subjective view of what is actually going on, to your point about whether they're going to check the A1C or not. So to really start looking at this broad set of medical problems that are extremely common, unfortunately, that are related to obesity, whether it's type 2 diabetes, whether it's sleep apnea, whether it's hypertension, and targets this to determine whether somebody could travel to a place or not, is just very disturbing. Of course, it's understandable when there is a problem that is very focused in its scope, like an epidemic, where there is an immediate threat to public health. You do want to have some kind of control. But these are far and few in between occasions like that, right? That could come up when we've had an epidemic like 4 years ago, right? But to talk about health issues in general and even think about employing physicians who have taken an oath to treat everybody equally in terms of treating them for their disease, but to have physicians even to participate in this type of approach is
Mhm.
very, very problematic, of course, Kamal.
But I think the issue is no one is going to have like morbid obesity crisis all of a sudden. It's not an acute problem, right? So this is a chronic issue in a
Absolutely,
way. So
absolutely.
um, I would understand if you do drug screening for the visa application.
Mhm.
That would make sense. You may not want to have someone who has a really bad drug use history. I can
Mhm.
maybe understand that. But if you are not looking at any of those, I wonder if he's just doing these things to get, some attention. I don't know. A lot of things. I try to support him
But,
just
but,
because
but,
it's.
but also the issue of trying to reduce healthcare costs. There are many other public policies that could be implemented to reduce the issue of obesity in our
Mhm,
society, right? Whether it is regulating the production and distribution of certain foods, whether it's improving infrastructure around living spaces where people can walk, jog, or
mhm,
bicycle without having any problem, whether it's implementing nutritional education in schools at all levels. All these are good policies that could pay off in the long term in a tangible way.
mhm.
But to talk about this broad way of assuming that obesity is a foreigner that has come to America,
Mhm.
it just doesn't make any sense. If anything, we as a society are exporting
Now,
obesity
one thing,
because of the health habits that we are promoting.
Trump is obese. He has morbid obesity.
Well, it's a common condition.
I mean,
It's a common condition, yeah, in our
you think
society.
his, I would put $100 that he's more than, his BMI is more than 35. And he has other conditions, comorbidities that he would be morbidly obese. So, like, if he applies for it, then he won't be able to come to United States if he was in, Europe from where Melania is. So he wouldn't be able to come in.
Right, right. But I mean, the whole issue, though, here is that we are talking about really castigating people for no fault of
True.
theirs, right? We're saying, because you have this disease, as if a disease is something that somebody goes to get themselves, right? And as physicians,
It's a little
that we
what
have
motivates
taken
him.
allegiance to protect to treat everybody equally, it would be a very big problem for physicians to participate in any type of activity like this.
No, I mean, if he was in super good shape, and then he wants everyone to be like him, then I understand, but that's not the case, right? So I won't put you on the spot for this one, Dr. Guy. I'm going to move on to the next question. What if what happens with the other people from other countries that are coming here to actually get the uh, bariatric surgery? So that means we are going to tell them no, like medical side of this with the business.
Absolutely, absolutely. So you're absolutely right. I
Mhm.
mean, bariatric surgery is a very effective treatment for morbid obesity. And in the United States, we're very proud to say that we have one of the best and most advanced bariatric programs, from around the world. We are actually a leader in obesity treatment just because of the quality improvements that we've been
Absolutely.
able to implement in our program. So people naturally will look to the United States to come and get treatment because they have trust in what we have been able to build, and therefore that this kind of approach will certainly create barriers. It will magnify the stigma around obesity, which we're trying very hard. You're trying very hard through your broadcasts on Bariatric Friday, trying to really
Hmm.
undo the damage that has been done with
That's
stigmatization.
that's why I brought it up. Yeah.
Absolutely. So it is going to be something that is going to be a major obstacle, really, in when people try to get treatment.
So this can become a bigger problem in the future if we actually follow this perspective or perception. So then next you're going to say you don't want people with certain backgrounds to come here as a tourist. Then you're going to say you're going to take it to a different. It's a very dangerous situation for public. So do you see from the public health standpoint the risk of excluding these medical conditions? What are certain risks that we may have?
Well, again, we are going to really interfere with prevention and with treatment because once you stigmatize a condition,
Mhm.
you are sending it into hiding, right? And we're already having a hard time convincing people to understand that obesity is a disease that they should come up and seek treatment. And as you know, only 6% of people with obesity actually seek medical care, and that's including weight loss medication and surgery.
Mhm.
And so we have huge, huge task in front of us to try to get everybody to understand that it's a disease. Now, if on top of this you're going to add more stigmatization, you really are going to make our job even a lot harder. So you're not going to have any
Mhm.
positive impact. You're just going to magnify the problem essentially.
Now, while he's doing this, on the other side, he's doing something really good with cost control, pricing control for GLP-1 medications.
Hmm. Hmm.
Um,
Hmm.
so there's some inconsistency. I
Hmm.
actually want to be in his advisory team and make sure that I can take those people who are, influencing him in the wrong way.
Hmm.
Maybe
Hmm.
you and I, we should be there together. So
Definitely.
he needs help because he's trying to do a lot of good stuff. He did this with the insulin. Now he's doing it with the GLP. These things are no reason for these things to be this expensive,
Mhm.
right?
Absolutely.
So the only reason it's because it's not generic yet.
Mhm.
So now the pharmaceutical companies charging, uh, you know, it's almost unreal what profit they make from this.
Oh yeah, there is a real crisis of access to
Right.
care to these
And
medications.
like
Yeah.
when I see someone who's controlling this and then trying to make these things more accessible, available,
Mm.
and then on the other hand, just saying that, oh, you can't come to US because your BMI is 40. Oh, by the way, I couldn't be able to come back to US either because it just it doesn't work.
Yeah.
So,
Yeah.
but I think he's trying, but sometimes the things trying doesn't work. So now GLP is. Dr. Gao, I have to tell you with the GLP utilization issue, I think there is a huge problem.
Mhm.
Now, as you know, when I have new employees who are in my team, I do one-on-one training, and I don't see those as training, but I see those opportunities for me to one fix certain issues in the system.
Mhm.
The other thing is that we want to kind of point out certain issues when we are explaining to someone. We can actually see those issues much better.
Mhm.
So, Phil just joined us a couple of weeks. Now it's 2 weeks now, I believe. So, and we are going through certain projects that we already have in place. And as I'm explaining why we are doing it, I'm like,
Mhm.
okay, so here's the very expensive drug,
Mhm.
and here's the patient who's been on it for 3 years. And in our study, you remember with the 6 and 12 months, how much these people lost weight, how many of whom lost 2 digits, how many of whom gained two
Mhm.
digits. So, and I want that number, the total patients in that study to be like 250, 300. Right now, we are, I believe, 135. And this is not working.
Mhm.
So, yes, there are some, maybe 10% of the people that are getting good results,
Mhm.
but 90% of the people are not. And in that, like 10% of the people, they're actually gaining weight.
Right.
So, and one of the issue is the side effects.
Mhm.
So many people are ignoring the side effects. So, what I would like to ask you is, what are the most common side effects of GLP-1 medications?
So the most commonly seen side effects are gastrointestinal side effects. So people may feel bloated, they may have nausea, they may have vomiting, they may have constipation, diarrhea, they may have abdominal discomfort.
Hmm.
And of course, all these also are symptoms that can have either come, one symptom only or more than one
Hmm.
symptom, and also they can be uh, varied in terms of their intensity as well. So for some people there may be more, and others it may be very little. So You could have somebody having a little bit of nausea maybe in the morning and then it goes away, or you could have somebody who have persistent nausea that interferes with their quality of life. But these are the more common. The gastrointestinal side effects are the more common side effects that are seen.
These side effects comes with very important risks. So what are some serious risks patients should be aware of?
Well, there are some very serious risks. Obviously, something like a gallbladder attack, gallbladder problem, that can become a serious inflammation. Another very serious side effect is something called pancreatitis, which is really inflammation of the pancreas. Now, there are different degrees of inflammation, but it can be inflamed enough to become a life-threatening condition as well. Now, much more rarely, things like cancer, certain type of cancer of the thyroid can occur, particularly with people who have a certain family history of a certain type of thyroid cancer. And very rarely, there have been reports also of blindness, associated with this class of weight loss medications.
So the issue I really want to actually discuss with our other providers, which we started the discussion before, but when you don't see the results, why do you keep the patient on the same medication? I mean, I have a problem with that. So if the patient if they're not on on GLP-1 because of diabetes, which I don't think that should be the first choice anyway. So if you are actually adding this as a third medication for weight loss, and they have not lose any, why are you still keeping the patient?
So exactly, and I think part of the reason for that, Kemal, is the fact that we're not approaching the problem with a multidisciplinary program in place. Ideally, I would like to see a program where you have, of course, the primary care doctor, the internal medicine expert, or a bariatrician that does the medical side. I would like to see a nutritionist, but for particularly high levels of obesity, I would like to see an involvement of a bariatric surgeon early, right? Where all the options could be discussed. So if the patient is started on medication and they're progressing well, we're all happy and they continue. But once we see that there is not enough progression, at a certain point, the discussion has to happen about alternatives as well. And for certain levels of obesity, the most effective treatment we have is bariatric surgery. So just like in the model of cancer, where we have a multidisciplinary approach, we should have that kind of approach here as well, where we're all prepared to deal with what we know is a chronic disease. And there are going to be responders to certain type of medication or interventions, and there are going to be non-responders, and there may be partial responders as well who may require more than one approach. They may require surgery and medication. And it's okay for us to approach it in this way because our goal ultimately is to liberate that patient from obesity.
Absolutely.
So you're absolutely correct. Persisting on one avenue of treatment without any significant outcomes does not make sense because all you're doing is exposing that person to potential side effects without any tangible benefits. So at some point, we have to change direction. We have to reevaluate what we're doing and then see what other options may be available.
Right.
Yeah.
So we know that some bariatric patients, they are also using GLP-1s. How should bariatric patients use GLP medications differently?
So obviously there has to be more care when it comes to bariatric patients because bariatric patients will have had some changes in their gastrointestinal system that predispose them to some of the side effects that I talked about earlier, whether it's nausea, whether it's constipation, whether it's diarrhea, particularly the procedures that require intestinal rerouting like gastric bypass. So is it okay for these patients to have availability of weight loss medications, the GLP-1 receptor? Absolutely, absolutely, because you can come into a situation where a patient, who weighed 450 pounds, they needed to lose 250 pounds, but they may have bariatric surgery and then they may stop at 200 pounds. They still have some ways to go, and we can add medication to really magnify the effect of the surgery. So that can be very, very effective. So But when you use them, you have to be careful. We have to make sure that adequate hydration is occurring. We have to make sure that they're taking all their necessary vitamin supplementation as well, so that they don't fall behind.
Absolutely. And I have those. There are two patients right now. They're over 400, and to bring them to a safety zone for the BMI,
Yep.
they do need more help. So
Yep.
then, yes, of course, we are actually seeing those. Um, and again, the main issue is the measurement of these. So,
Outcomes, yeah.
what I see is like patients started on this and they didn't have any in-person visits, so they go with the reported weight. And I'm always kind of honest with myself. So if I mean, I don't like being weighed at the you know physician's office, and when they ask me, I'm usually 10 pounds off. But our patients are averaging about 35 to 40 pounds. I see that. So the patient would jump from the on the result screen. So you see them, they're like 375 pounds, and then next time you send a video visit, they're already all of a sudden they lost 40 pounds, but then when they come in person, they're like back to 385. So if you don't measure these progress, then I don't think we are the medical society, like medical clinicians, are doing a good job in keeping, as we said, keeping these patients on these medications have big consequences for them if they're not benefiting, especially from those. Um, Now, do you think GLP-1 medications can replace bariatric surgery?
No, no, they can supplement bariatric surgery, but they cannot replace it. There is no way there's no comparison right now. The most effective treatment we have for long-term treatment of morbid obesity is still bariatric surgery. That's where we see the best outcome so far. But is there a subset of patients that would be better off just with medication? Absolutely, particularly if the weight is not very high, if the comorbid conditions have not evolved so much. Yes, you can consider the medication. In fact, it's absolutely okay to start with medication. But it is important, as you say, that once you recognize that that patient is not responding to that treatment, and then have them consult a bariatric surgeon. Of course, ultimately the patient will make a decision on which way they want to go. The most important achievement, in my view, about getting medications available right now, particularly powerful medications like the ones we have, which are way more powerful than the ones we used to in the past, is the fact now we are able to convince a larger part of the population that it's okay to come to the doctor asking for help when they are overweight,
Right.
when they are morbidly obese, as opposed to suffer silently as if that was something that just themselves they had to take care of, right? So that exposure is very, very important. But then as we move, we should recognize the subset of patients who will do better with medications, the ones who will benefit with bariatric surgery, and the ones who will benefit with both approaches.
All right, so the serious part of the session is over. So we are gonna play a little game.
Okay?
So we didn't invent this, so I can just be again honest. So I see certain people doing it, and I think we are more qualified to do this.
Okay.
So we are going to play a little game, and this is the game is called Rated with Dr. Erggo.
Wonderful.
So I'm going to give you. There will be a picture on the video, so you don't see them, but you just need to know the names. So you're going to give me 1 to 10,
Yeah.
where you would how you would rate these food. So I'm hoping that they made the correction. With I see it, they did.
So 10 is the best,
10 is
the highest, and
10
then
is the
1
highest,
is the lowest.
right?
Okay, got it.
So, and just so that before I don't want to interrupt the game, so I'm not drinking whiskey. So, and one dumbass friend of mine just messaged me, "Are you drinking?" I don't. It's a lemon balm. So, because one of the other friends said, "Don't use the mug, use the glass." So in the first session, so I switched, but then the color is, of course, misleading. So no, I'm not drinking. Ready?
Yeah.
Okay. So Turkish yogurt. How would you rate that?
I would say a 10. It's an excellent source of protein, calcium, and probiotics. I like the texture, it's thick and filling. It's really ideal actually for our bariatric patients, but I always tell them choose a plain, low fat version essentially.
Absolutely.
Yeah.
Um, Next one is brown rice.
Brown rice, I would say 6. It's a complex carb with fiber, but people have to be careful with the portions, obviously, because of the calories that go with it. Small
So
servings only.
one thing, if I can suggest, there's a buckwheat. I think that actually is much lighter.
Yes.
Maybe next time we play this, I'm going to bring that up for
All
you.
right. Very
And
good.
I use it. They're coming from Russia. I don't know if we don't have it here. So now the next one is you see it in my yard, in my garden. I tried to raise them avocados.
Oh, avocado, 8. Very healthy fats, and it has lots of fiber as well. It's great in moderation. People just have to watch the calories because it can have a fair amount of calories, but it's a very healthy, definitely.
So once they are growing, so I'm going to make sure that we have some fresh ones. So what about protein bars?
6. It really depends on the brand. People should really aim for low sugar and high protein, and be careful about the brand. Some of them are just glorified candy bars. So
Right.
6.
So, all right. Vitamin B12.
Oh, 10. This is really critical, particularly for our patients, our bariatric patients. It's available as a sublingual or an injection, really, in terms of availability. So excellent.
And I get the monthly injections, although my PCP didn't prescribe. Iron supplements.
10. Again, essential, particularly for our bariatric patients, particularly for women, because there is obviously more loss for them. So very, very important. It's important actually that they take it separately from calcium as well, because many of our patients who are on iron are also with calcium.
All right. The next one is you see it in my fridge, almond milk.
I would say a 6. It's a low calorie dairy alternative, but I would say I'm worried about the content of protein, which is not very high. So the reinforced version would be better.
And I think I know the answer for the next one is white bread.
The lowest is 1. I would say it was
We
1.
can go with
It
the
really
negatives.
offers minimal nutritional value and it spikes the sugar. People really should avoid it.
So the next one is omega-3 capsules.
8. It's really beneficial for the heart and also for the brain. So, should use verified brands, but it's really excellent.
All right, we're getting to the finish line here. Dark chocolates.
6, 70% cacao or higher is fine occasionally. It's a good antioxidant, but obviously the calories can be very high.
All right, so my new discovery is my next question is the lemon balm.
8. I know you would want me to give it more than that, but
12, 12 is the right one.
I would say 8. It's a natural calming aid, essentially. It's good for digestion and sleep. And people should avoid the sweetened brands, obviously.
This is actually really good. I don't put anything in it other than lemon. Perfect.
Excellent.
So this one also is new. I didn't bring it with me, and I know a lot of people don't know much about this. Kombucha gummies.
I would say a 4 probably. It does have some probiotic benefit, but it's not like the natural type. So
I'm gonna disagree with you on that one.
okay, yeah. So people need to understand that there is a lot of sugar in it, and the potency of this kind of preparation may not be as strong as the natural
Well,
one.
also the game name is rated with Dr. Erkan. It's not like rated with Kemal. So I'll go with what you say. But I think I also started that.
Did you really?
So
Okay.
that's not. I think I started. But I was gonna say I would actually tell you more about that probably in a month.
Okay.
Between the lemon balm and that kombucha gummies,
I'll be happy to stand
sometimes
corrected.
you feel there are certain things that you start taking and then you don't feel anything.
Mhm,
But
mhm.
These two are good.
Maybe it's the lemon balm more.
All right. Well, no, lemon balm is, of course, like more natural. I
Yeah.
think that's why it would be a better choice. So I will bring this game time to time
Yeah.
with
Nice. That's
different,
great. Yeah.
products and options. And for the audience, if please put in the comment section if you can put what you want us to rate next time. I read those all the time, so one by one. So I would be more than happy to bring them up. So that's all we have today. So thank you so much, Dr.
Thank
Gal, for
you.
joining
Yeah,
us
that was
again.
wonderful.
So our goal is to give the most objective clinical information when it comes to morbid obesity. And I know a lot of others who don't have morbid obesity they're also following and they're already reporting back to us that they are benefiting from what they see. And it's extremely rewarding to see people taking advantage of what we are presenting here. So we'll be back next week with another session of Bariatric Friday. Next week, we are going to discuss navigating holidays for bariatric patients, and anyone actually can benefit from it. So that's our kind of annual discussion. So we always do that. So we'll see you next week. Well, until then, stay united. Bye bye.
Stay united.